Today, we will focus on what we do with the PK estimate and how we use it for creating a treatment plan. So we have the same patient we were using last week. Enter patient one. I go into their record, and I have prepared a few PKs because I will show you, they will be useful for the points I need to make. But let's start from the one we loaded last time. Last time, K, where we had a measurement at 1 hour, a measurement at 3 hours, and we had a 75 person treated with 2,000 units of Covaltry. And now you see that the request PK button has changed to a view button. Now you have access to the estimated PK. So I click on view and I get the PK report. I'll ask for confirmation to Leo. Leo, do you see a PK moving on the page? Yes, okay. So let's take it a piece at a time. This is the result review function. You have the patient data, so the identifier, the name we gave to the patient, the number, the specific estimate. If we request more than one, this number will identify the specific PK estimate. The age of the patient, you see the age twice. One is the age as of today, calculated using the date of birth of the patient, and the other one is the age at the PK study. In this case, is the same, but we would be in other situation reviewing today the PK of a 48-year-old patient that actually was done when he was 40 or so on. Then you have the body weight, the height, the lean body weight, which is an important determinant of PK. So we put it here to let you see if it's similar or different from the actual body weight. If you want to obtain a peak of 1, you would need to give 50 IU per kg of lean body weight. So if you give 50 times 75 to this patient, you will get 1 point something. If you give 50 units per kg times 58, you will get 1 or 100%. And then other covariates. So this is just to make sure we know exactly who this patient is and their characteristics. Then there is a graph. This graph shows the fat concentration at time 0, the moment the patient infused, and you see that the peak for this time was 0.72 with 2,000 units, infusing 20 IU per kg. And you see in red the measurement that you have provided as a base for PK calculation, and in green you see the estimation of the PK. The continued green line is the best estimate. The dotted line are the confidence interval. This is an estimation, so is as good as the data we give, and by only giving 2 points around peak, there is some uncertainty later on in the curve. If you move your pointer down this line, you'll see the concentration at different times. So at 24-hour, we expect 14%. At 36-hour, we expect 7%, and so on. Okay, then you have 2 tables. The first table just tells you back the data you have given. At 1 hour, this patient had 75%. 0.75. At 3 hours, this patient had 0.55. This 55%. These were the measures. This is the PK estimate. The half-life, the last line of this table, is estimated at 12 hours, 12.75. That's the balance. That's the best guess. But given the data we provided to the system, and given the PK in the population, it could be as short as 8.5, as long as 19.5 hours. So 12.75 is the best guess the most likely, but it could be as short as 8, as long as 18. Back to this concept. This table also shows you the hours needed to get to 5%, 2%, 1%. These are critical points. 5% is considered safe. This may be old. Nowadays, we would consider safe 15 maybe. We could discuss and update this table, but when we started 12 years ago, 5 was considered safe, 2 was considered the valid target, 1 was the minimum ever. And for each of these target threshold, the table shows you how many hours will be needed to get there. So after the infusion, 43 hours to get to 5%, 61 hours to get to 2, 77 hours to get to 1. And then you have the conservative and the optimistic estimate. And you see that if we consider, for example, 1%, this patient is likely getting to 1% after 77 hours. 77 hours is about 3 days, but it could be as short as 49 hours, 2 days, or as long as 126. This is 4.5 days. So this PK is not perfect. There's a lot of residual uncertainty. To help you build a treatment plan, the last table shows you the concentration after 1, 2, 3, 4 days. And if you like to see this in hours, you can click here and you'll see after 24, 48, 72, 96, and so on. I'll prefer to see days. And again, after 1, 2, 3, 4 days, this patient, best guess, will be at 13. So 13%, 4%, 1% at 3 days. This is the basic PK profile and estimate we provide. You may ask me, why don't you give me AUC? Why don't you give me clearance? Why don't you give me mean residence time? Don't you have them? Can't you calculate those? I sure can, and actually WOPS does calculate all of those to be able to generate this table. The reason we don't put them in the report is that we really serve clinician on the field. We serve a clinical practitioner, and they don't need any of that. You don't use clearance to talk to a patient. You don't use AUC. You use time to concentration. That's what helps you in a clinical conversation. We can go back in discussion, but this is really what many years of practice and dialogue with colleagues around the world are led us consider. What is really needed is time to concentration. Okay, so this is a PK profile. Now, the point I want to make now is how can we reduce this variability? So keep in mind, fix in your brain the image of this confidence interval very much apart at 12 hours, 24 hours, 36, 48. They are quite apart. And we are estimating using 1 hour and 3 hours. Now let me go to UK. So I go back to the patient page if I succeed, and I use this second PK. In this second PK, we have 1, 3, 24, and 48. Leo, can you see a new screen? Yes. Okay, so now I'm providing the system 1 and 3 as before, but also 24 and 48. I ask the patient to come back the day after and the second day, and I draw blood. And if you look now at the graph, you see how narrow this has become, because I'm not guessing based on early points. Now I have late measurement, and the confidence interval are very narrow. Now, if I look at the half-life, is the best guess is still 1275, 12 hours. But now I'm saying is 12, it can be 11, it can be 14. But now that I have all this information, it can't really be much far from 12. And here are the best estimates. And if I look at the time to concentration for 3 days is 1%, can be as low as 0.9, can be as high as 1.8, but it is really a narrow estimate. So if you were to ask me what are the ideal point, I would tell you, well, you know, I can work with 1 in 3 hours, but for sure, if you give me 24 or 48, I can work much better. Now, let me move this a bit far. Stay here. I'm now only providing 48. Now, this patient is on 2,000 units Monday, Wednesday, Friday. You see it now on screen. If I put my mouse on this grid, I see the treatment plan. You recall that when we provided the PK data to WOPS asked us, do you know the last infusion? And if you didn't know the last infusion, the second question was, do you at least know the treatment regimen? And the treatment regimen here was 2,000 on Monday, Wednesday, Friday. So the system knows that this patient is on 2,000 3 times a week, and also knows that after 48 hours from the infusion, it was at 4%. Now look at the graph with only 1 point, but a late point. Now the graph is very narrow for the tail of the curve. 12 hour, 24, 36, 48, very narrow. The estimate around the time, the concentration at 3 days is really narrow. It is 1.3% best guess, 0.09, 1.9, very close to 4 points. It was 0.9, 1.8. So, you know, all the information on the tail is still there because we gave a 48 point. Where there is more variability now is at peak, because I don't have any information around peak. And so I'm precise in the tail, but I have some variability in the peak. I would not be able to predict peak concentration and judge if this patient on this dose is ready for surgery. So not only the precision varies with different points, but depends what you're looking for. If you're looking at optimizing trough, you'd better provide a late point. If you're looking at precision in peaks, you better provide early point. One last so let me go to the list of PK. The first one, the one with lots of variability, was 1 in 3 hours. At this one, I'm using 1 in 3 hours only, but this time I draw the dose. I draw a sample before.
You're breaking up a bit.
10 pills at 1 on. Okay, sorry. I'll repeat. Tell me, Leo, if I continue to break.
Yeah.
So now 2 PKs. One that is the 1 in 3 hours only, and the other one is 1 in 3 hours plus a pre-dose. So this time.
Oh.
Was this clear, Leo?
No, you ended at this time 1 in 3, and then the last 20 seconds or so was blank.
So I have no way of improving the connection. I'll try again, and you tell me if it's clear. The only difference between these two infusions is that in the second one, I had a pre-dose measurement. The patient in the second infusion was sampled before the infusion of factor. 10 minutes before the infusion of factor, we measured the plasma level of factor VIII. Okay?
Yep.
Okay, so I show you the graph. This is the graph. I have the pre-dose, the 1 hour, the 3 hours.
No graph yet.
Oh, sorry. Tell me when the graph shows up.
Yep. It's
Now it's
there.
up.
Yep.
Okay. So on this graph, you have a pre-dose, this point down here, and then 1 hour, 3 hour, the red line. Pre-dose, 1 hour, 3 hour. Okay? Okay. So in this case, I have early point and a pre-dose, and you see that the confidence interval are very narrow. They are as narrow as when I was providing 24 and 48. Can you follow? Can you hear me?
Yep.
Okay, so by providing a pre-dose, we allow WOPs to know the late concentration, and the confidence interval shrinks a bit. I show you again. This is the graph by using the pre-dose, and can you see a new graph now?
Yep.
This is the graph without the pre-dose. See how broad, how wide these confidence interval are? Because I have a lot of uncertainty on the late portion of the curve. Instead, if I provide the pre-dose, that uncertainty is eliminated. Again, can you see a new graph?
Yes.
Okay. Okay, so if someone asks me what is the best combination of points to get all the information we need, I would suggest this one here, pre-dose and peak. You can get these all in 3 hours. The patient get to clinic, you ask about the previous infusion, you draw a pre-dose, give a dose, and then you have a peak, 1 hour, 3 hour. This is the best combination of points that is feasible in clinical practice. Okay, now this is how to read a PK profile, and this is also trying to answer about the best point to provide the system to get maximum precision. Now we move to the clinical calculator. So once I have a PK, and from now on we use this one, the one with the pre-dose, I go into the clinical calculator, and now I have a chance of modeling a regimen for the patient. So this patient, for example, was on 2,000 units and was on an irregular treatment, Monday, Wednesday, Friday, 2,000 units. So the age is there, the body weight, the height, I can change if they are different, but in this case, let's assume they are the same. I only put the dose and the interval, and then I ask the system to calculate for me. And what the system does, it calculates for me the profile for this patient on this treatment regimen. And you see this complicated graph where you have in dark green the best guess of the profile, and then you have in red the optimistic In dashed red, the optimistic, in dashed green, the conservative. When you talk to a patient, if you don't want to see all this line, you go for the simplified plot, and you only have a simple line that says the peak and over time the concentration down to the trough. The same information is provided to you in a table here. This table tells you the patient takes 2,000 units 3 times a week. There are 2 short intervals, 48 hours, Monday to Wednesday, Wednesday to Friday. And then there is a long interval, Friday to Monday. The peak goes higher and higher. It starts on 74% on the Monday, 76 on the Wednesday, 77 on the Friday. The trough is 4%, 3.9. On the Wednesday before the infusion, 4.1. On the Friday before the infusion, and of course on the Monday is 1.3 because the interval is longer, so the concentration goes farther down. Another way of looking at this is looking at the weekly dose, 6,000, 2,000, 3 times. The patient is all the time above 1% because the lowest he gets is 1.3. Is 89% of time above 3 and is 41% of time above 15%. Okay? Okay, now let's say this patient tells me that he bleeds on Sundays. Okay? He happened to bleed on Sunday. And so I say, well, okay, let's try to make a change to your treatment plan. And the first thing is, let's try to change the dose on the Friday. So look at here, you get a 1.3, is 89% of time above 3%. Now I say, okay, variable dosing, I click here, and now I'm requested to tell how much. 2,000 on Monday, 2,000 on Wednesday, let's say 3,000 on Friday. I increase the dose on Friday to try getting better off on the Sunday evening. Now I ask the system to calculate. And what happened here is that you see a bigger peak on the Friday because I'm giving a higher dose, so it goes higher up. And then hopefully it will stay more protected. Now, if I go and look here, instead at 1.3, he ends at 1.8. It's not a huge difference. The time above 3%, instead at 89, is now 93. Again, it may be enough, but is a very, very minimal change. And if the patient is not bleeding on Monday, Tuesday, Wednesday, Thursday, maybe his protection is around 3%, 4%. So I didn't make a change that is significant. Let's try another change. For example, we say, you know what? I'm giving you 2,000 units, but I'm treating you every other day. Every other day. Sorry, I have to say every other day, so regular every other day. Now the system tells me this is the graph, and peak is 77, and trough is 4.1. Now the time above 3% is 100%. Of course, the patient is getting more concentrate. He was on 6,000 before per week, now it's 7,000. But he gets full protection. Now the patient tells you, I can't really treat every other day. Can you find some dose for me that allow me to get to these 4%, magic 4%, by treating every 3 days? The calculator will try to help you answer this question. This time you say, okay, I don't know the dose. I know that I want the patient to stay at 4% or higher. and I want to treat the patient every 3 days. So now I ask the calculator to model 0.4, so 4%. Every 3 days, I'm asking for the dose, and I ask to calculate. And do you see a new graph? Now,
No. Oh, yeah.
no?
Yep.
Okay. Now there's a warning. Says, well, this dose is really high. The patient has a really high peak. To get 0.4, treating every 3 days with Covaltry, you would need to give 7,500 units, which is a lot and gives a very high peak. Of course, this would be 18,000 units a week, would give full protection, but this is not feasible. So the answer to the patient is no. With your PK, I can't give you any dose, any reasonable dose every 3 days. Now, this was a patient that was bleeding, okay? And so we really want to use the best guess. But say this was a patient not bleeding. He was on Monday, Wednesday, Friday, 2,000 units. He was not bleeding, doing well. And now it tells you, is there any dose that I can take every 3 days with a reasonable expectation not to bleed? You could use here the optimistic estimate. So say, well, you know, this patient is not bleeding. Maybe we want to use the best estimate, the most favorable interpretation of the half-life. So I put this cursor here to optimistic. I continue to ask for a 4% trough every 3 days, and I ask for the dose. Now the system is redoing the calculation, assuming this patient has the most favorable PK of those reasonable. And it's actually working. This patient would get there with a dose of 3,000 units every 3 days. He would have a peak of 0.9 and a trough of 4. He would use 7,000 units a week and be always against 100%. Now, of course, being able to use the optimistic or the conservative estimate depends on the clinical behavior of the patient. This is not something that WOPS will tell you. You will know by knowing the patient if it's reasonable to use the conservative to make sure the patient will never bleed, or the optimistic in a patient that doesn't usually bleed and is likely doing well and can take the risk of treating less intensively, less frequently. If I have saved all of these treatment plan while generating them, which I did, and I go back to the patient page, I will have all the PKs that we have used for this tutorial. And if I go under treatment plans, I will have all the treatment plans. I'll have the one with 2,000 Monday, Wednesday, Friday, 6,000 units a week. And here I have peak and trough. I have the 7,000 a week, Monday 2,000, Wednesday 2,000, Friday 3,000 with peak and trough. I will have the 2,000 every other day, 7,000 a week, peak and trough, and so on. So once I've generated all the possible treatment plan, I have them listed here under treatment plans. I can view them. If I want to see again, you see this one says you use the optimistic to generate this one. For all the other, we use the balance. I can choose the one I want to discuss with the patient. And if I click on view, I go back on the other page where I have all the estimates, both the simplified or the conservative estimate. This is the end of today's tutorial. I hope, notwithstanding the technical issues, to have been able to help you in the interpretation of a PK, in the comparison of different PK, in understanding which points are valuable as source of information and in how to use the calculator to generate a treatment regimen. Thank you very much.